Welcome back to my YouTube channel. If you are new to my channel, welcome to Medical Insight. Hi, I am Nishaba, a certified medical coder. In this video, we will discuss some important case study questions related to integumentary system along with quick elimination method to solve them easily and efficiently. Patient is 55-year-old female who yesterday underwent Mohs surgery with Dr. Smith to remove the basal cell carcinoma of her scalp. Due to the size of the defect, Dr. Smith requested a plastic surgeon to reconstruct the site. Dr. John discussed with the patient his planned closure, which was a yin-yang type flap. The area was prepped and wrapped in a sterile fashion, being careful to keep betadine solution out of the open wound. Wound preparation was done by excising an additional 1 mm margin to freshen the wound and excising the wound deeper. Starting on the right, Dr. John inside his planned flap, elevating the flap with the full thickness and subcutaneous fat staying superior to the galea. Then Dr. John's inside his planned flap on the left, elevating the flap with full thickness and subcutaneous fat. Both flaps were rotated together and the wound was temporarily closed using the skin stapler. Once it was determined there was a minimal tension on the wound, the galea was approximated using 5 nocrel. The wound was closed in layer using 5 nocrel and 35 hour skin stapler. Meticulous hemostasis was achieved throughout the procedure with the pubic artery. Final measurements of the wound were 36.25 square centimeter. What CPT code is reported? Option A with the service code 11,620, 14,301 along with modifier 51, 15,004. Option B with the code 14,301, 12,031 along with modifier 51, 15,004. Option C with the code 14,021, 15,004 along with modifier 51. Option D with the code 14,301, 15,004 along with modifier 51. Surgical preparation and reconstruction of basal cell carcinoma on the scalp using yin type flap with final measurement of 36.25 square centimeter is performed. A yin flap is a rotation flap coded using adjacent tissue transfer codes 14,000 to 14,350. Always remember, while coding for adjacent tissue transfer with code of defect size which is less than 30 square centimeter, it is coded based on the location and size. When it is more than 30 square centimeter, it is coded using codes 14,301 and 14,302. Based on size, we will first eliminate option C with the code 14,021 used for the adjacent tissue transfer of scalp with defect size 10 square centimeter to 30 square centimeter. We will also eliminate option A and B with codes 11,620 for excision and 12,031 for repair, used along with adjacent tissue transfer. As adjacent tissue transfer codes includes both excision and repair, and we will not use them separately. Option D with the code 14,301 is reported for the first 30 square centimeter to 60 square centimeter. Wound preparation was also performed. For wound or surgical preparation, we use the code range 15,002 to 15,005. Code 15,004 is reported for the scalp. Modifier 51 is used to indicate multiple procedures were performed. So correct option is option D with the code 14,301 and 15,004 along with modifier 51. Diagnosis: basal cell carcinoma. Procedure: Mohs micrographic excision of skin cancer. Site: face left lateral canthus eyelid. Preoperative size 0.8 centimeter. Indications for surgery: area of high recurrence, area of functional and or cosmetic importance. Discuss procedure including alternative therapy, expectations, complications, and the possibility of a larger or deeper defect than expected requiring significant reconstruction. Patients' questions were answered. Local anesthesia 1 into 1 Marcan and 1% lidocaine with epinephrine, sterile prep and drip. Stage 1, the clinically apparent lesion was marked out with a small rim of normal appearing tissue and excised down to the subcutaneous fat level with a defect size of 1.2 cm. Hemostasis was obtained and a pressure bandage placed. The tissue was sent for slight reparation. Review of the slide show clear margins for the site. Repair, complex repair, repair of wounds, micrographic surgical defect. Wound margins were extensively undermined in order to mobilize tissue for closure. Hemostasis was achieved. Repair length 3.4 cm. A layered closure was performed. Multiple bullet absorbable sutures were placed to reoppose defect. The epidermis and dermis were reopposed using monofilament suture. There were no complications. The patient tolerated the procedure well. Post-procedure expectations, including discomfort management, wound care, and activity restrictions, were reviewed. Written instruction with urgent contact numbers given. Follow-up visits and suture removal in 3 to 5 days. What CPT and ICD 10 cm codes are reported. Option A with the code 13,152, 11,642, along with modifier 51, C44.311. Option B with the code 17,313, 13,152, along with modifier 51, C44.119. Option C with the code 13,152, 11,442, along with modifier 51, C44.311. Option D with the code 17,311, 13,152, along with modifier 51, C44.119. In the given scenario, Mohs micrographic excision of basal cell carcinoma of skin of the left lateral canthus of the eyelid is performed in stage 1 with defect size of 1.2 cm followed by complex repair of length 3.4 cm. In the CPT index, when we look for most micrographic surgery, we are directed to code range 17,311 to 17,315. Based on the code range, we would first eliminate option A and C with the codes 11,642 and 11,442 used for the excision of malignant and benign lesions. Most micrographic code selection is based on location and stages. The operative note indicates that the location is on the face and only one stage is performed, making code 17,311 the correct code choice. According to the guidelines for most micrographic surgery, repairs are coded separately. This is a complex repair on the eyelid measuring 3.4 cm, making 13,152 the correct code choice. Modify 51 is used to indicate multiple procedure. In the ICD 10 cm, the code C44.119 is for the basal cell carcinoma of the skin of the left eyelid, including canthus. So, our correct option is option D with the code 17,311, 13,152, along with modifier 51 and C44.119. A child is brought into emergency department after having her fingers on her right hand closed in a car door. The physician evaluates the patient and diagnoses her with a 3 cm laceration to her second finger and a subungual hematoma to her third finger. The physician then proceeds to cleanse the fingers with an iodine scrub and inject both digits with 2 ml of 1% lidocaine with epinephrine. The wound on the second finger was then irrigated with 500 cc of normal saline and explored for foreign bodies or structure damage. No foreign bodies were found, tendons and vessels were intact. The wound was then reapproximated. 3-5 absorbable matter sutures were used to close the subcutaneous tissue, and 6 nylon interpret sutures were used to close the epidermis. The finger was then wrapped in a sterile gauze and placed in an aluminum finger splint. The physician then checked the digital block performed on the third finger was still effective. After ensuring the patient's finger was still numb. He then proceeded to take an electronic cautery unit and created a small hole in the nail. Pressing slightly on the nail, he evacuated the hematoma. The hole was then irrigated with 500 cc of normal saline and the finger was wrapped in a sterile gauze. The patient tolerated both procedures well without complaint. Option A with the code 12042 along with modifier F6, 11740 along with modifier F7. Option B with the code 64400 into 2, 20103 along with modifier 51, 12042 along with modifier 51, 11740 along with modifier 51 and 59. Option C with the code 20103, 12042 along with modifier 56, 11740 along with modifier 57. Option D with the code 20103, 12042 along with modifier 51, F6, 11740 along with modifier 51 and F7. In the given scenario, three absorber matrix switches are used to close the subcutaneous tissue and six nylon interface switches are used to close the epidermis. A two-layer closure is used for repairing a 3 centimeter laceration on the second finger. An evacuation of the subingual hematoma was done on the third finger of the right hand. We will eliminate the option B, C, and D with the code 2103, which is used for surgical exploration and wound enlargement to remove the foreign body. Since the wound in this scenario do not require enlargement, extension of dissection, or removal of foreign body, for such wound, we will only use the appropriate repair code from the integumentary system. Option A with code 12042 is used for the intermediate repair of the layer closure with modifier F6 indicating the procedure was performed on the second digit of the right hand. Subingual hematomas are injury to the nail bed where the bleeding developed under the nail. Code 11740 is used for evacuation of the subingual hematoma with modifier F7 indicating the procedure was performed on the third digit of the right hand. So correct option is option A with the code 12042 along with modifier F6 and 11740 along with modifier F7. Preoperative diagnosis, lab breast abnormal, MMX or palpable mass, other disorders of breast. Procedure, automated stereotactic biopsy of left breast. Findings, lesion is located in the lateral region, just at or below the level of the nipple on the 90-degree lateral view. There is a subglandular implant in place. I discussed the procedure with the patient today, including risk, benefits, and alternatives. Specifically discussed was the fact that the implant would be displaced out of the way during the biopsy procedure. Possibility of the injury to the implant was discussed with the patient. Patient has signed the consent form and wishes to proceed with the biopsy. The patient was placed prone on the stereotactic table. The left breast was then imaged from the inferior approach. The lesion of the interest is in the anterior portion of the breast, away from the implant, which was displaced back towards the chest wall. After imaging was obtained and stereotactic guidance used to target coordinates for biopsy, the left breast was prepped with betadine. 1% lidocaine was injected subcutaneously for local anesthetic. Additional lidocaine with epinephrine was then injected through the indwelling needle. A Senorex needle was then placed into the area of interest. Under stereotactic guidance, we obtained 9 core biopsy samples using vacuum and cutting techniques. The specimen radiograph confirmed representative sample of the calcification was removed. The tissue marking clip was deployed into the biopsy cavity successfully. This was confirmed by the final stereotactic digital image and confirmed by post-core biopsy mammogram left breast. The clip is visualized projecting over the lateral anterior left breast in the satisfactory position. No obvious calcium is visible on the final post-core biopsy image in the area of interest. The patient tolerated the procedure well. There were no apparent complications. The biopsy site was dressed with steri-strips, bandage, and ice pack in the usual manner. The patient did receive written and verbal post biopsy instruction. The patient left our department in a good condition. Impression: 1. Successful stereotactic core biopsy of the left breast calcifications. Number 2. Successful deployment of the tissue marking clip into the biopsy cavity. Number 3. Patient left our department in a good condition today with post biopsy instructions. Number 4. Pathology report is pending. An addendum will be issued after we receive the pathology report. What are the codes for the procedure? Option A with the code 19081, option B with the code 19101, option C with the code 19081 and 76942 along with modifier 26. Option D with the code 19283. In the given scenario, an automated stereotactic biopsy of the left breast was performed using Sonoric needle to obtain the biopsy sample. To start narrowing our choices, first check was the biopsy performed percutaneously or by an open incision. The operative note documents that a Snorix needle was used to obtain the biopsy. We will first eliminate the option B with the code 19101, which is used for the open incisional biopsy. Code 19081 is used for the breast biopsy with placement of breast localization devices when performed percutaneously for the first lesion, including stereotactic guidance. Since placement of breast localization devices and image guidance is included in code 19081, it is not necessary to code for the placement of breast localization devices and image guidance separately. We will eliminate option C with the code 76942 used for the ultrasonic guidance for the needle placement. We will also eliminate option D with the code 19283 used only for the placement of breast localization devices without image guided breast biopsies. Our correct option is option A with the code 19081. Preoperative and postoperative diagnosis: squamous cell carcinoma, left leg, open wound, right leg. Personal history of squamous cell carcinoma, right leg. Indications for surgery: the patient is an 81-year-old white man with biopsy proven squamous cell carcinoma of his left leg. I marked the areas for excision with gross normal margins of 5 mm and I drew my planned skin graft donor site from his left lateral thigh. He also had an open wound of his right leg from a squamous cell carcinoma excised 4 months ago. The skin graft had not taken. We plan on reskin grafting the area. The patient is aware of all these markings and understands the surgery and location. Description of procedure: the patient was taken to the operating room. IV NSAID was given. I used plain lidocaine for his local anesthetic throughout the procedure until the skin grafts were inset. The anterior of his leg and the thigh were infiltrated with local anesthetic. Both lower extremities were prepped and wrapped circumferentially, which included the left thigh on the left side. I excised the lesion on his left leg as drawn into the subcutaneous fat. Hemostasis achieved with Bowie cautery. I then excised the wound on his right leg to lower the bacterial counts. I took a 1 to 2 mm margins around the wound and excised the granulation tissues as well. Hemostasis was achieved using the Bowie cautery. I then changed gloves. A split thickness skin graft was harvested from the left thigh using Zimmer dermatome. By this time, the pathology returned showing the margin were clear. Skin grafts were inset on each leg wound using the skin stapler. Zeroform and the gauze bolster was placed over the skin graft using 4 nylon. The skin graft donor side was dressed with opsite. The legs were further dressed with heavy gauze padding and a double A strap. The patient tolerated the procedure well. Procedures were excision squamous cell carcinoma left leg with excised diameter of 2.5 cm repaired with a split thickness skin graft measuring 5.1 square centimeter. Excisional preparation of the right leg wound prepared with a split thickness skin graft measuring 3.2 square centimeter. What CPT and ICD 10 codes are reported. Option A with the code 15,100, 11,603 along with modifier 51 and LD. 15,002 along with modifier 51 RT C44.729 S81.801A. Option B with the code 15,100, 15,100 along with modifier 51 LT 11,603 along with modifier 51 LT 15,002 along with modifier 51 RT S81.801A. Option C with the code 15,100, 11,403 along with modifier 51 LT 15,100 along with modifier 51 RT C44.729 S81.801A. Option D with the code 15,100, 11,603 along with modifier 51 and LT. In the given scenario, excision of squamous cell carcinoma on the left leg is performed with an excised diameter of 2.5 cm and the wound is repaired with split thickness skin graft measuring 5.1 square centimeter. Additionally, excisional preparation of the right leg wound is performed, which is repaired with split thickness skin graft measuring 3.2 square centimeter. First, we will eliminate option C with the code 11,403 used for the excision of benign lesion. We will also eliminate option D as excisional preparation of the right leg is performed. We will have to use the code from the code range 15,002 to 15,005. The first excision is for the malignant neoplasm of the left leg measuring 2.5 square centimeter. In the CPT index, when we look for the excision of skin malignant neoplasm, we are referring to the code range 11,600 to 11,646. The site is the leg, which narrowed down the code range to 11,600 to 11,606. The size of the lesion is 2.5 centimeter, making 11,603 correct. The second excision is the surgical wound preparation of an open wound on the right leg. Surgical wound preparation is represented by the code range 15,002 to 15,005. Report code 15,002 for the leg wound. Since both legs wounds are repaired with split thickness autografts, the areas of both are summed together for a total graft size of 8.3 square centimeter. Option B, which lists split thickness graft for each leg separately, will be eliminated. The code range 15,100 to 15,121 is used for the split thickness autograft. Report code 15,100 for the split thickness autograft, which is used for the trunk, arm, or legs for the first 100 square centimeter. Since the original surgery of the right leg was performed 4 months ago, this surgery falls outside the global period and no additional modifier is needed. Modifier 51 should be appended to indicate multiple procedures performed in the same session. For ICD-10 coding, assign code C44.729 for squamous cell carcinoma and S81.801 for the open wound on the right leg. So our correct option is option A with the code 15,100, 11,603 along with modifier 51 and LT 15,002 along with modifier 51 RT C44.729 and S81.801A. Thank you for watching. If you have any question or need further clarification, Please feel free to write in the comment section. For more detailed guidelines, CPC mock exam related questions and notes, email me at the giving email ID.